Hey everybody, welcome back to the ECG channel with Reed. My name is Reed, and today we're going to go over our first class of antiarrhythmics, which are sodium channel blockers. And these are an interesting set of medications, and what they do is, obviously by their name, we are going to block our sodium channels. And we know that if we look at our depolarization of cells, it is controlled by sodium rushing in phase 0. So sodium channels are predominantly active in impacting our action potential here at phase 0. Okay, so what do sodium channel blockers do? They decrease conduction velocity, and they do that by depressing the slope of phase 0, right? So instead of being this steep slope, phase 0 might be a little bit slower, right? As time is on our x-axis, it might take a little bit more time to depolarize. And so that is how we would kind of generally understand these medications. And I'm going to go into a few of the subclasses of our sodium channel blockers because they're not all the same. So let's talk about that briefly. So our first subclass of sodium channel blockers is class 1A. In class 1A, they not only block sodium, but they also block our our potassium channels, which is our phase 3, or they really affect repolarization, right? Our potassium channels, repolarization. And our potassium channels, if you remember, that is phase 3, right? So phase 3 is our repolarization. And so by blocking our potassium channels that are causing repolarization, we are increasing our refractory period. So this is going to increase our refractory period. And so how is that going to change our action potential curve here? Well, what we'll see is we're obviously going to decrease our sodium channel potential, and so we'll get slowing of our initial action potential. The rest of this will be relatively the same, but by prolonging phase 3, it is going to take us longer to get down to our baseline again. And so if you've noticed here, the total refractory period gets longer. And so because of that, we're increasing the refractory period. These drugs can be pro-arrhythmic. And so we use them for very specific disease states. We can use medications like quinidine. And quinidine is really great for people with Brugadas. We also have medications like procainamide. And procainamide is really good for atrial tachyarrhythmias, like AFib. It's really good for pre-excitation syndromes. And as you can imagine, right, if I look over here at my heart in the upper right-hand corner, if I have a pre-excitation syndrome where I have some communicating between my atria and my ventricles, well, if I block the conduction velocity, I'm going to slow the conduction through that current, or through that accessory pathway. Similarly, if I have an atrial tachyarrhythmia like atrial fibrillation, I can suppress these reentry pathways in atrial fibrillation that are conducted by decreasing the conduction velocity. And if I selectively decrease the conduction velocity, then I might be able to terminate that AFib. And so those are my class 1A medications. Next, we're going to talk about class 1B. 1B. And these ones are, sodium channel blockers as well, but they actually shorten phase 3, which is our repolarization. And so they're modest depressors of phase 0, so they don't depress phase 0 as much as our 1A agents. So we'll get an increase in our action potential like normal, and then it actually shortens phase 3. And then it returns back to its baseline. So if you notice, our refractory period is actually shorter in this case. And so it decreases our refractory period. These are really good for ventricular tachyarrhythmias. And examples of these medications are lidocaine and mexiletine. So people might be taking these if they have a long QT syndrome, right? By shortening refractory periods, we are essentially decreasing their QT intervals. On the other side, right, if we are increasing their refractory period, we're going to increase their QT intervals, right? So start to think through how this might affect your ECG if someone's on these medications. And the last class of the last subclass of these sodium channel blockers is going to be our class 1C. And class 1C are the strongest sodium channel blockers, and they have no change in phase 3. So if you notice, all of these subclasses are essentially by, one, how strong of sodium channel blocker are they, and two, do they influence our repolarization period? And so how is this going to affect our action potential? Well, because they're the strongest sodium channel blockers, they're going to decrease the slope of phase 0 the most. But if you notice, we will return back to our baseline at the same time as our normal action potential. And so our refractory period remains the exact same. And so what are these medications best for? Well, they could be used for supraventricular tachycardias, but these patients must have no structural disease or like LV dysfunction, right? We're decreasing the conduction velocity a lot because these are strong sodium channel blockers. So by decreasing the conduction velocity a lot, if we have a structural heart disease, this is going to be a problem. So they're contraindicated in structural heart disease or heart failure. And these can be used, like we said, to cardiovert people from supraventricular tachycardias, maybe like AFib. Some examples of these medications are flecainide and propafenone. And so what I want you to get out of our sodium channel blockers is, one, they all decrease the action potential velocity, right? They decrease conduction velocity. So if you could imagine, these are really good for faster heart rates that we need to slow down either re-entry of some sort. Remember that some of them will increase our refractory periods, such as 1A. So 1A is going to increase refractory period by blocking those sodium and potassium channels, specifically that are for the repolarization in phase 3. That is ultimately going to increase the QT interval, which represents our repolarization on our EKG. 1B, they will shorten phase 3, so they will actually decrease the QT interval. And so this could be used in people with congenital or genetic causes of long QT syndromes. And then class 1C are the strongest sodium channel blockers, so we want to be really careful when we use these in patients who have structural heart conditions, but they don't increase their refractory period, or they do not increase our QT, so our QT stays the same. So these are QT neutral. So I hope this kind of summary of what sodium channel blockers do helps you, and as you kind of work your way through the uses of these medications, understanding how is it slowing conduction velocity, and why is that going to help with this arrhythmia, right? If it's atrial fibrillation, we know that we have all these fast reentry circuits in the atria. Same with atrial flutter, ventricular tachyarrhythmias, like monomorphic VTach. So I hope this helps, and have a great day.